This is a problem which can happen in any department, any medical specialty. Sometimes we do get persons with any kind of illness, sometimes unconscious, sometimes it's so disorganized that person is not able to tell his or her name or whereabouts. And generally, such patients are present in emergency settings. And sometimes in person with head injury who is in unconscious state gets admitted to one or other departments, and depending on the uh, coexisting medical or surgical conditions, person would be shifted to the specific disciplines as he or she recovers from the regains the consciousness. Now, today we will be presenting, and some of the cases would be of mental illness. So, today we are presenting two such cases. Uh, One of them was a female patient with in late pregnancy, and second one had presented in trauma with the enucleation. Now, presenting these patients are a major challenge if a mental illness is recognized, or even otherwise also, to the treating clinician where to send this patient when the person improves. A person is not able to tell his or her whereabouts. Now, if the person is having mental illness and person is generally the person improves with treatment, except in cases of where there has been a cerebral damage where the person may not improve because of the irreversible damage. So, we'll be discussing two patients. Uh, uh, the challenge has more become more pronounced after the Mental Health Care Act, which came in 2017. Because before that, it was like you would refer such patients to mental hospital, that the Institute of Human Behavior and Right Sciences. But now, under the new act, we can't send the patient to IBHAS or Institute of Health, Human Behavior and Life Sciences, or any other psychiatric hospital. You have to manage them and rehabilitate them also. So here we will be discussing that how we manage these two patients, taking help from other disciplines also. And we also have Dr. P. Kumar, additional professor, hospital administration. We requested him to come here to discuss about the administrative issues involved in this case. I'll request Dr. Rahul Mathur to begin the presentation.
Thank you, sir. Good afternoon, everyone. So, addressing homeless persons and unattended patients with mental health issues is a very common and challenging thing, which we commonly see in an emergency setting. So, hereby I'll be presenting two such cases, which were brought to the AIIMS emergency by the police IOs and were successfully managed in inpatient setting in AIIMS. So, first case is a case of psychotic self-inoculation. He was a 34 years old unmarried male, which was brought to the ophthalmology RPC emergency, from where he was referred to trauma emergency, from where contact with the psychiatry on-call team was made. He was brought by police with alleged history of self-inoculation and odd behavior, and was found wandering alone in the streets. On initial examination, the patient was overly groomed and camped. He had lid edema. He had watery discharge from the right eye, and he had minimal opening with the left eye. On initial interview, there was sudden onset of crying and agitation was seen. His speech was non-goal directed and speech flow was increased. On further mental status examination, he had delusions of grandiosity and persecution. So 2 weeks prior to the day of admission, patient was residing in Chennai. He was working as a software engineer. He was residing in Chennai in a private hospital. He stopped the medication few weeks back and had altercations at workplace. So the medications which he was previously on for his psychiatric illness. Thereafter, he didn't sleep for 2 days, but he still continued to be energetic, and his goal-directed activities were increased. He increased his time spent in gym and on online activities. On Instagram, he saw actress Tejasvi Prakash's pic, and he believed that she was in love with him. He did some online shopping. He brought 18,000 INR worth gold and some expensive carry bags and clothes and other stuff to gift her. A week before the admission, patient booked tickets online to go to Delhi, as he got to know from her Instagram post that she was also in love with the patient, and she wants him to attend her show in Delhi. His family members became suspicious about his behavior, as he was in constant touch with them over phone call. His parents were in contact with the hostel warden, where he was living. He also had an altercation with the hostel warden when he tried to help the patient in seeking psychiatric consultation. His appetite was reduced considerably, and his sleep continued to decrease, and he talked at length with his friends about his love story with the actress. 3 days before, patient came to Delhi alone, and he informed his parents about the decision. His parents by then had informed the Delhi police at the airport, but they were unable to reach him. In Delhi, he left his belongings at the airport. He took a taxi and went to meet her love at some place in Dwarka. He reportedly consumed some unknown substances, after which he complained of seeing bats and building around him moving. He heard some people talking about themselves, and he heard some words like badam, khol do, and nahi chodenge, from which he misinterpreted that they were planning to sexually assault the actress. He considered himself incapable of protecting her, and he developed severe anxiety and restlessness. Thereafter, patient reported he took out his eye out of shame, guilt, and anger as he was unable to protect his love interest. Following the episode of enucleation, he left his eyeball on the streets and was found wandering alone along the streets. Police was informed by the nearby people, and he was taken to the DDU hospital. And after initial stabilization, patient was referred to AIIMS Trauma Center, from where ophthalmology consultation was sought. And in the initial examination, patient was uncooperative. Therefore, psychiatric consultation was also sought. And after acute management in the ophthalmology, the patient was admitted under psychiatry. Subsequent upon the admission, patient's family members were contacted, and this was a history which was received from his father. Patient already had three previous episodes of mania in 2012, 20, and 21. And 21, the episodes in 2021 was severe enough to warrant an admission in the psychiatric ward. He also had one depressive episode in 2013, where he was again admitted because at that time patient reported of self-harm ideations. So upon admission in the ward, the first challenge was to diagnose the patient, and four differentials were listed. The first was substance-induced psychosis. Second was organic psychosis, pernicious mania, which is a condition in which there is manic symptoms along with delirium. And lastly, bipolar affective disorder with current episode mania with psychotic symptoms. His organic workup was done. The urine drug screen came out to be negative. The nutritional deficiencies were corrected. The patient had severe vitamin B12 deficiencies and had borderline serum sodium, which was corrected. His serial monitorings of blood parameters and vitals were done. And upon taking the neurology consultation, his autoimmune profile, EEG, MRI brain, and PET scan were done, which didn't showed any signs suggesting of organic pathology. For the psychiatric management, patient was started on tablet haloperidol and tablet lithium, as patient had past history of response to both of these medications. Within a week of admission and optimizing the dose, patient showed significant improvement in his symptoms. For the ophthalmology management, a regular dressing was done, and eye ointment and antibiotics were started as advised. So this case has the following highlights. The patient was unattended initially without any capacity for consent. He had severe mental illness and prevented communication of address. Patient shown considerable improvement and reported remorse about the events within the 3 days of treatment. His family members were traced, and his father was already in contact with the Delhi police. Therefore, in this case, we have seen that there was active participation by the family members in the treatment. There was minimal administrative and legal support was required as family members arrived quickly. Patient was successfully discharged with the family members with supervised medication and was asked to follow up regularly from Chennai, and telephonic contact was made with his father. So coming to the second case is a pregnancy and a delivery in homeless mentally ill woman. She was a 43 years old married female. Currently, she was residing in Delhi. She was living alone. She was residing with her 10-year-old boy. Was not formally educated. Was belonging to Hindu nuclear family of low socioeconomic status, and she was found wandering along the streets with complaints of odd behavior and aggressiveness. She was initially taken up by Delhi Commission for Women, after which she was brought to the AIIMS emergency by the police. She was unaccompanied by any person and denied having any family members. On initial examination, patient was conscious and alert. She was poorly groomed and kept and had hallucinatory behavior in form of smiling and muttering to self. Upon abdominal examination, the patient's abdomen was distended and striae gravidarum was seen, and she had fundal height of about 28 weeks. In her further mental status examination, delusion of persecution and disorganization of thought was seen. Patient was admitted in C1 psychiatry ward, and for the initial few days, we were not able to take any reliable history, and no corroborative information was obtained. Police IOs, though they were able to trace the husband, but the husband was reluctant to accept the patient. We then even tried to contact the husband, but phone was not picked up after the initial call with the husband. Lastly, her sister and aunt were traced, and history regarding her illness was taken from them. From the information collected, it was seen that she had been suffering from a psychotic illness for about 20 years. Since about 20 years, patient had persecutory ideas towards her sister as well as her father, and she had recurrent altercations with them. And in the early 2000s, she left her home and she started to live with her aunt in Delhi. She also had persecutory beliefs against her aunt, who she believes that they were also involved with her sister and with her father. She had odd behavior, and there was history suggestive of delusional misidentification, maid volition, hallucinatory behavior, and unprovoked anger episodes. She got married multiple times in between 2010 to 2020, details of which we were not able to make. She worked as a commercial sex worker, and she even indulged in substance use. Regular alcohol and tobacco use was seen, but not up to the dependent pattern. She had child with her second husband, and the husband took away the child, citing patient's mental health as the reasons. She had no fixed source of living, and she continued to do odd jobs like working as a maid and as a commercial sex worker. She was living in shack in Delhi with a 10-year-old boy who would work as a house help, and he was the only care provider for the patient. This was a history which we got from her sister and her aunt, and we can see that from the 2000s and even prior to that, patient had progressively worsening psychotic illness, and she was never taken for any psychiatric consultation was never taken, and she was off medications for about 20 years of her illness. So, upon admission to the ward for the psychiatric management, after a few weeks of the admission, when the diagnosis was made, patient was started on tablet olanzapine from psychiatry, which was gradually built up to 20 milligram, uh, and patient showed considerable improvement after second week of her admission. For her obstetric and administrative management, we can see that first of all, patient's regular antenatal checkup was started. She was registered under JSSK program, and during the second week of admission, it was seen that patient hit her abdomen twice, and emergency USG was done, which was within normal limits. Dexamethasone for maturation of lung of the baby was also given, and patient uh, patient had no abnormalities for the obstetric part. Regarding the administrative issues, private attendant for the patient was arranged from the hospital as she was unattended. Letter to the medical superintendent was sent, and MSSO of the hospital and IO were informed to find the family members. She was constantly asking to meet her 10-year-old child, which was subsequently informed to the IOs, and patient started demanding discharge from the second week onwards. Subsequently, MSSO visited the patient, and patient communicated with her 10-year-old boy through a video call arranged by the MSSO. By the fifth week of admission, patient developed vaginal candidiasis, upon which the successful management was done. And by this point of time, after dose optimization, patient had considerable improvement in her psychiatric symptoms. She gave consent for the delivery, and patient was taken for delivery and she delivered a healthy baby boy by sixth week of admission. And until whole this period, patient was in the C1 psychiatry ward. In fifth week of her admission, Ayu visited the patient, and patient agreed to stay in ward, and she was planned to discharge to the NGO Matritva Chaya, where contact was made, and it was made possible that patient, her 10-year-old boy, and the baby can be kept together. So this case highlights that she was an unattended patient. Her family members was traced and contacted, but they were reluctant to help her, which was unlike which we have seen in the first case, where the family members were actively involved in the case. It also highlights involvement of various stakeholders like a psychiatrist, an obstetrician, hospital administration. As the patient initially, she didn't even had her any ID, which was made possible by the contributions from the hospital administration and the MSSOs. Subsequently, and we also seen that patient was initially she was not willing to keep the baby, and she even punched herself in the abdomen. But once the patient regained insight and of her illness, and she showed improvement in a psychiatric symptom, she gave consent for the delivery. Subsequently, patient was discharged with the police IO to the NGOs for the homeless woman. Thank you.
Good afternoon, everyone. Before I invite Dr. Kumar, we agreed that 5 minute summarization takes away a lot from the complexities of these cases. For example, in this lady who was staying hereabouts in Delhi and the Delhi Commission of Women picked her up, the history in the history she will say that all the person whom she was living with was her own husband who has changed her face. So that was the delusion of misidentification. And because there was no corroborating evidence, even till the end, we do not know how many times she was married or maybe she was abused. Additionally, the 10-year-old child, we do not know whether it was a second child, which she sometimes still says was taken away by her husband, or whether it was another child. But nevertheless, the living situation is that a 10-year boy looks after this woman, and the woman has been brought to us. Similarly, after admission, when there was a unit discussion and discussion with hospital administration, after hearing or gathering much of the story, it was decided that we'll keep the patient with us till delivery. And this summarization does not give you the whole amount of work that residents of gynecology, psychiatry, and at the end pediatrics did to get the things done. For example, she needed to be included in the JSSK, which is the government's program. But to get her included, we need an ID. To get her ID, we need an Aadhaar card. So essentially, we started with her Aadhaar card, went to a BPL card, then went to her enlistment in a program, and then even at the point of discharge, she was unwilling to keep her baby. So again, NGOs came and pediatric social workers who were there, MSSOs came, and the baby was sent to another place. She still wanted to stay in the Juggi with her own son. So we had to find a NGO which was also agreeing to take her son. So, nevertheless, this gradually, like Professor Chadda was saying, is becoming more and more of a problem because of the current Mental Health Care Act. And so we thought this is a wonderful opportunity to invite Dr. Kumar to talk about homeless and other patients and how we are managed at AIIMS as a protocol. Thank you. Dr. Kumar, please.
Thanks, Dr. Kaushik, for the opportunity. So I'll be just taking the discussion forward and looking at it from three different scenarios. The first being the unknown unattended patient, that is unconscious and unattended. Second being conscious and unattended. And third, psychiatric cases who are unattended patients. All three of them have a similar protocol in this case, wherein the patient comes to the emergency, is screened and assessed by the resident there or by the CMO. In the case of an unconscious patient, the MLC is mandatorily done. Duty constable at the emergency is informed, and the MSSO who's posted in the emergency takes over this particular aspect where he documents the belonging of the patients, all the documents, and that is then handed over to the IO. Now, the IO has an important role to play. He is supposed to follow up with the patient, try and locate the patient relatives while the treatment is continued. In case of an unattended or an unconscious patient, of course, upon the request by the treating team, the hospital adam provides a 24 hours hospital attendant for the patient. Those patients who are conscious but without an attendant, similar steps are there, but just that the IO of the area concerned, where the patient is from, he is then contacted and then he takes over the investigation. An MLC may or may not be done depending upon the case to case basis as it is deemed necessary. Obviously, all the medication surgical items, since the patient is a state subject and the state responsibility, it is taken over by AIIMS. A separate form is filled by treating doctor. That is then taken in by the MSSO who does an assessment and puts it to the MS for approval. And all the items are provided from the hospital stores or through the local purchase vendor. This is a fairly streamlined system. In case of patients who are psychiatric, that is, patients with an unsound mind who's conscious, post assessment, the MSSO takes over. The police constable is informed. He is supposed to file an FIR with the local police thana. He is also supposed to try and locate the patient. If in case the patient is conscious enough or aware enough to tell his whereabouts, where he's from, the same role now taken over by the IO from that area. That's an important role that the IO takes over. FIR in this case is mandatory. Now, it is important that the psychiatric consultation is immediately sent from the emergency so that they can take a call on whether the patient has to be admitted or not. Now, in the past, like Sir just said, we could have actually requested IBHAS to admit our patients, but that is no longer possible under the new act. We are supposed to take care of our own patients. So I'll just come to the administrative challenges subsequently, just to know for the residents to know. This is the assessment form that is filled by the MSSO for any poor patient, which also includes unknown patients or unconscious patients. These are the details that the patient that the MSSO fills up to procure medicines and surgical items for any patients. Is also online available now. This is done again, a form filled by the MSSO for any patient who's unknown or without an attendant, and this information is filled up, double checked by the officer in charge, and then passed on to the IO for further investigation. The third form that the MSSO needs to ensure and is filled every single day is the time that from the time the patient is admitted in the ward to the time his discharge, he keeps an update of the patients, where the police is going, who have been contacted, and whether NGOs have been contacted or not. And in case of non-psychiatric patients, he has to ensure that the NGO is contacted for complete patient care. This is how it looks like a smooth story. It's often not that easy or not that streamlined. Some of the issues that we face because of psychiatric patients specifically is because, like sir said, now we have to admit our patients in our own hospital. If we do run out of beds in the C1 ward, then we might end up in a situation where you have to manage a psychiatric patient in a non-psychiatric ward, and that has its own set of challenges. It also is a problem when you have a patient in the emergency with psychiatric problem, with that situation to take care of the patient in the emergency when you don't have a separate cubicle or isolation ward for psychiatric cases is a challenge. And then, of course, hospital Adam has to coordinate with the MSSO, with the IO, with the courts, and often the treating team. The police, unfortunately, are often less than aware of the legal intricacies involved or the documentation thereof. So we kind of pitch in to help with that. One of the problems, I think, one of the case that we faced here was that either the family of the patient is not uh, identifiable, or they don't want to get involved, or their engagement with the police is not sufficient. One of the issues, of course, is a multidisciplinary case where multiple specialties are involved, and somebody has to call on the subsequent patient care. One of the case, like in this case, where a child is there along with the mother, and taking care of the child is also a problem. Thereafter, involving the NGOs is a challenge. And finally, smooth transition from hospital care to discharge to follow up and NGO licensing is a challenge that we have often faced, and we hope to get better as the time passes. Without further ado, I think I'll ask Dr. Kaushik to take over. These are just a brief highlight of some of the administrative challenges that we face. Thank you.
Uh, for the sake of brevity, I'll quickly go through. The change which everybody is alluding to is the Mental Health Care Act of 2007. The major change is that previously it was only for mental hospitals. Now it is for all healthcare institutions. There is some confusion to the fact if other wards rather than the psychiatry ward in which a mental health care patient is admitted, whether they come under Mental Health Care Act or not. But by and large, the definition seems to be inclusive to prevent human rights atrocities. So essentially, any psychiatric patient, even admitted in other wards, could potentially, in a legal sense, come under the Mental Health Care Act. Then it makes it, the other problem is that previously, like Dr. Kumar was saying, there was a Form 16 in which we could say that this patient would require long-term care and therefore it should be taken to a mental care home or a hospital. But now we cannot, and patients will generally prefer coming to AIIMS. And even family members, when they go in front of a magistrate who essentially orders, will sometimes say that they want to choose AIIMS. And therefore, we can potentially see a sudden increase in number of patients who are being brought by the police or the judiciary to AIIMS. The same thing has happened with disability certification, in which preference for AIIMS is very high. So the fact, to summarize everything from the Mental Health Care Act, is that two psychiatrists need to independently assess a patient, and even then, one has to prove that the patient has a harm to self or violence or harm to others or unable to take care. Only then, against the wish, which is called a high supported admission, the patient can be kept for 7 days for adults and only 3 days. And after that, we are supposed to inform the Mental Health Review Board, but it's still under formation. And if a patient comes to any other department, which can be considered as emergency treatment, so emergency, trauma, and other departments can keep a mentally ill patient for any physical emergency, for any treatment for only up to a period of 72 hours, within which the mental health specialist or the psychiatry department needs to be contacted. So roles of the other agency is that if a police finds, he has to go to the magistrate, and then from the magistrate he has to come to the health establishment. Of course, setups here are not well developed because our police IOs were not involved in such cases here, but the setup in other places are well developed. So, what has become clear is that we need to form some form of liaison with all the respective stakeholders, and beyond that, sometimes providing food, clothing, medicine, contacting the NGO, travel, money, ticket. We all know that our residents do it out of pocket, and it has been done for years. So I just want to make it a point that it's a good thing that we do. The challenge is, like everybody is saying, how to discharge. So in the second case, it was difficult. But what happens if the police cannot trace anybody? And AIIMS being a teaching institute, we had, I think our department had requested the Ministry of Health to exempt AIIMS out of this Mental Health Care Act because our beds are very precious. But from a human rights perspective, the ministry wants to be inclusive. Uh, so essentially, there can be some other areas in which collaboration can be done with other departments and the police so that police can accompany the patient home. So the purpose of this case presentation was more of a demonstration of the problems and the awareness that such changes are happening and we need to come together. Thank you.
The presentation is open for discussion. Any questions? We have Professor J.B. Sharma from Ops and Gynae. I'll request him to give his comments because unattended pregnant patients are also one of the not an uncommon problem, and unattended pregnant lady with mental health issue is a much more serious issue. Dr. Sharma.
Yeah, thank you, sir, and I congratulate you for managing this patient so well. And we really thank, whole team, hospital administration, sir, obstetric team, and all. We need to take care of these patients. Yes, obstetric is a big issue because many times that I want to take this opportunity to our male colleague of other department. Please, whenever there is any woman, think that they can be pregnant. Many times the patients are like on antipsychotic medicine and they don't have period often, either because of the severe mental disease, they may have amenorrhea, or because of the drugs also. Many drugs will cause hyperprolactinemia, the patient have amenorrhea. And many times like doctors are hesitant to ask them about their periods and patients are hesitant to tell them. So we have to ask them direct questions actually. Recently, when a 13-year-old girl, I had to go in operation theater. She was 26 weeks pregnant. It was missed by surgeon. So I'm not blaming anyone, but please always, I mean, even a 13-year-old girl can have pregnancy. So we should always think about it. In fact, it may be a good idea to do urine pregnancy test before any procedure in that, even in orthopedics are like, some patient can have like pregnancy, they can have. I recently, we had a patient in admitted in neurology. She was unmarried and she was throwing fits. So they were made that so status epilepticus. They were giving her anti-epileptic drugs. And actually, it just occurred to me, they rang me. I said it could be eclampsia. They said she's unmarried. So she was 28 weeks pregnant, intermittent death. 28 weeks was missed by our. So, like you, please always, this mind it. So, for the same patient, sir, your patient often have, and they're pregnant even up to 20 weeks. Nobody comes to know that they're pregnant. So, that means by that time, we have already given them drugs, which could have caused teratogenicity even without knowing. And by the time you will come to know she's pregnant, she's already 12 to 14 weeks. So teratogenicity period is already over. But the positive thing is that, sir, I mean, we should not deprive any pregnant woman of the treatment. She has to be treated for psychiatric treatment. Olanzapine is fairly safe. We have presented cases published also, safety of it. And another thing is that because these patients are not booked anywhere, so quite often we don't start them like drugs, anti and tetanus toxoid, iron, calcium, and all. So whenever, I mean, any such cases, they do send a call to us. We will see them. We will do ultrasound scan for them. We will book them, and we will help them. But thank you very much. So, and they can have little bit insight and growth restriction, nutrition issues, and all that. But otherwise, the prognosis is excellent, and perinatal outcome is good, provided they are treated further. Thank you.
Thank you, Dr. Sharma. I think we